Hello, my name is Kristin Wall, and I'm an assistant professor of epidemiology at Emory University. And today I'm going to be presenting data from a DFID-funded study looking at factors associated with female genital schistosomiasis, or FGS, as well as estimating HIV infections averted by treating FGS in adult women in urban Zambia. Neither I nor my collaborators have any conflicts of interest. So to begin with some background, female genital schistosomiasis is considered to be one of the most neglected tropical diseases in the world. It is caused by infection with Schistosomiasis hematobium, which is endemic in much of sub-Saharan Africa, where 90% of FGS cases are found. This equates to about 56 million women and girls living with FGS in sub-Saharan Africa. And unfortunately, FGS is associated with significant morbidities, including infertility, pregnancy complications, lost productivity and stigma, and additionally has been found to be a risk factor for both HIV acquisition and transmission. This is, of course, very concerning in sub-Saharan Africa, which, as you can visually see here, is home to most of the global burden of schistosomiasis risk, as shown in the map on the left, as well as concurrently being home to most of the global HIV burden, as indicated on the map on the right. So though schistosomiasis is still, unfortunately, commonly viewed as an infection affecting children in rural areas, considerable recent work, including from our group, shows that FGS also affects adult women in urban areas where HIV risk is also high. Our group previously explored the association between the schistosomiasis infection in adult women with HIV in an 18-year longitudinal serodiscordant couple cohort in Zambia. And we found that in HIV positive women, baseline schistosome-specific antibodies were significantly associated with HIV transmission with an adjusted hazards ratio of 1.4 and death with an adjusted hazards ratio of 2.2. And in HIV negative women, we found that the presence of schistosomiasis hematobium specific antibodies were associated with increased risk of HIV acquisition with an adjusted hazards ratio of 1.4. Our findings are similar to a recent meta-analysis by Patel et al. From the CDC, which indicated that schistosomiasis increases HIV risk in women twofold. So the objectives and rationale for the current analysis are given here. First, we evaluate factors associated with FGS positivity to build a simple diagnostic algorithm. Our rationale is that despite an urgent call from the WHO for treatment of FGS in adults, adult praziquantel coverage is currently very low, and that's largely due to difficulties in diagnosing FGS. The current gold standard diagnostic technique for FGS uses colposcopy, which is not currently affordable or feasible in most of Africa. Second, using data from our high-risk cohort, we also estimated the number of HIV infections averted by treating high-risk adult women with praziquantel to support increasing diagnosis and treatment of FGS in adults. Our data come from a cohort of high-risk women in Lusaka and in Ndola, Zambia, who were recruited between March 2020 and September of 2021. Adult HIV negative female sex workers and single mothers were recruited, and participants completed a survey assessing FGS risk factors, and they underwent colposcopy for gold standard diagnosis of FGS. We first evaluated factors associated with FGS positivity using logistic regression, and we built a diagnostic algorithm using standard derivation and validation methods. Among 536 women in the cohort, the overall FGS prevalence was high at 23.5%. And you can see in the table here the various components of the risk algorithm that was arrived at from the derivation cohort. This algorithm consists of a very simple checklist of variables that could be assessed in a government clinic. The Hosmer-Limschow test of goodness of fit indicated good calibration. The risk algorithm had reasonable discrimination, and using a cutoff score of 3, the risk algorithm had 71% sensitivity, 60% specificity, 35% PPV, and 88% NPV. We also used findings from our previous publications of the effect of FGS on HIV acquisition risk in women, along with the HIV seroincidence rate observed in our cohort and the cost to treat FGS using current drug prices for praziquantel in Zambia, to build a compartmental model outputting the number of HIV infections prevented and the costs of treating women with FGS in our cohort. So in addition to the very high prevalence of FGS that we also found a high HIV seroincidence in our cohort of 2.7 per 100 person years. And from our compartmental model, we estimated that treating women for FGS with praziquantel in our cohort would prevent 15% of new HIV infections at a cost of $130 US. And this is applying standard recommended single dose one-time treatment regimens for praziquantel. So in conclusion, we found that FGS in adult women living in urban areas is, the prevalence is concerningly high. And given that this high FGS prevalence was observed concurrently in a high HIV risk population, it is urgent that FGS diagnosis and praziquantel coverage, which is an inexpensive drug with few side effects and no known resistance in Zambia, increase among urban adult women. This is one of the first studies to develop a simple, feasible diagnostic algorithm for use in government clinic settings. And in future work, we'd like to validate our algorithm in government clinics. And we also found that a proportion of HIV infections may be preventable by identifying and treating FGS in adult women. And in future work, we'd like to evaluate the assumptions we used about lesion resolution in adults after treatment. So I would like to conclude by thanking and acknowledging my collaborators, study staff, and study participants. And I thank you all very much for your time.